And what we're going to be talking about with this module now is looking at red blood cell issues and some platelet issues. Okay? Now in chapter 41 that talks about all kinds of different hematologic disorders, those also cover your white blood cell disorders, but you're going to have that in 202. Okay? So just the conditions that I talk about this morning are the only ones that we're going to be looking at as far as testing and for this module. All right, so don't feel like you got to know all that myeloma and leukemia and all that stuff, because you'll get that in 202. Okay. So when we're talking about hematologic disorders, let's just do a quick review on the hematologic system. When we're talking about anatomy and physiology, these are your major structures and components of that system. The bone marrow, which is where we have primary production of red blood cells, white blood cells, and platelets. Okay. This is we find these production areas mostly in the spine, in the vertebrae, the ribs, the sternum, and then the long bones. The liver certainly plays a big part. This is what manufactures our clotting factors. It also helps to remove old red blood cells from the circulatory system. It's where they go to die. Okay? The spleen does this as well, but it also works to store platelets. Okay? So it stores platelets and it helps to produce antibodies that stimulate platelet production. So when we have issues with the spleen, we have problems with what? Platelets, and therefore clotting. Okay? And then, of course, y'all know we got lots of blood in there. That's the whole point, right? So your blood is responsible for transporting your oxygen and carbon dioxide, and then it's also responsible for maintaining hemostasis, maintaining good blood volume in there. And we've talked about that whole procedure and process, how the body helps to do that. When we're talking about red blood cells, those are also called erythrocytes. And these come from the bone marrow. And we need a hormone called erythropoietin that is produced by the kidneys, which is what stimulates red blood cell productions. Do you remember that word? Erythropoietin. And what kicks that hormone in is when we have a decrease in oxygen level in our body. Remember, we get hypoxic, the body kicks in to produce more red blood cells, so hopefully we can carry more oxygen around. So we need erythropoietin, which is produced from the kidneys. So when we have kidney problems, we may have issues with our red blood cell production. Okay. A big part of your red blood cell is your hemoglobin, which is what actually carries the oxygen. And remember, it's a molecule. You need the heme part to carry the oxygen, and the globin carries the CO2. But what do you have to have in order to have the heme part? You have to have iron. So when we're talking about some of these anemias, when we have a decrease in red blood cells, it may just be because we've got a decrease in iron in our bodies. Platelets are thrombocytes. They activate the clotting system. And just like you need erythropoietin for red blood cell production, you need thrombopoietin for platelet production. So if we've got issues with platelets, we've got issues with clotting. Your clotting factors, there's a whole bunch of them out there. Y'all can probably tell me how many there are. But these are what, when we have a damage to an artery, a vein, the platelets kick in, the clotting factors kick in, and everything goes to that site of damage. And that's when we start to have clot formation and fibrin laid down and all that business, that big long clotting cascade that I'm sure you guys learned. And then plasma is the last part. Plasma is basically the fluid that is in the blood. It carries your red blood cells and platelets and all those things throughout the body. It's mostly water and protein and albumin and globulins. Here's kind of a picture of how your blood kind of falls out. If you notice, the biggest majority of it, about 55% of it, is plasma. It's just the fluid component. Okay, you've got a few little white blood cells and platelets in there, and then the next biggest thing is going to be your red blood cell component. Okay. So the majority is plasma. So when we're talking about the function of your hematologic system, you got two functions. One is oxygenation, and the other one is hemostasis, just like we talked about. Okay? Oxygenation, you've got to have the red blood cells available. They need to be available, they need to be enough of them, and they need to be functioning in order for us to carry oxygen and carbon dioxide and that kind of business. You've got to have that hemoglobin component. And then your blood is also responsible for hemostasis, and we do that through our platelets and that clotting cascade. So maintaining correct blood volumes. Okay. You do have a picture in your book in Iggy on page 859 that shows that clotting cascade. Just kind of refresh your memory on that. All right, I'm not going to ask you about factors and all that business that has to do what factor happens first. Good Lord, I hope y'all remember that. But that's a very involved cascade, a very involved process. But be aware of, on that chart or on that picture, it shows you where your different medications act during that cascade. So you see where your anticoagulants act. You see where your platelet inhibitors act. Okay? So our two major functions, to get oxygen out there and to prevent blood loss or maintain our blood volumes, hemostasis. Now you know, just like we've talked about everything else, everything has an age-related component, right? Things just don't work as well when we get older. We've talked about that. But what happens when you get older in regards to your hematologic system? Your bone marrow becomes less productive. All right, just less productive. It will kick in when it needs to, but it takes it a little longer to kick in, and it'll meet the demand, but it just takes longer. So it does work. We just need to be patient and hopefully get our patients stable while that's working. But the function of that system is really not affected by age. It still works, it's just slower. Now, the function, if your patient is really greatly stressed, or if your person has some type of chronic illness, a trauma, chemotherapy, those things will affect the function of the hematologic system. But again, we need to be aware of that and know that we may have to intervene earlier in those cases. Okay, but usually just by the getting old, you're really not affecting that system. There is a chart on 861 EGI that talks about changes in as we age. So things like our nail beds become thicker, maybe a little discolored. So it's a little difficult to monitor capillary refill in your elderly patients. Have you seen that when you're out there assessing your folks? Little more difficult to assess. So we may need to find other parts of the body to assess when we're looking at blood flow. Where else can we look? Maybe the toes. Where else? You can look at the conjunctiva. You can look at the mucous membranes. Okay, pink. We're looking for pink. Okay, especially in your African Americans, we're definitely going to be looking at conjunctiva. Maybe some of the palms of the hand, but mostly we're looking at conjunctiva. That's your best way to look. Okay. Okay. The skin becomes drier, of course, as we age, and sometimes I know that Mr. Welch has talked about some conditions that you have that the skin gets dry because of decreased circulation, right? Can you think of anything he's talked about that has that problem? Right, peripheral vascular disease, right. So just because we've got dry skin doesn't mean we have peripheral vascular disease or circulatory problems. As we age, our skin color changes a tad. Most of the elderly people that you take care of, they're pale. Okay. They're pale. They may have a yellowish tint to their skin. So when we're looking for somebody who has liver problems, what do we look? What's one of the first things we look at? We look for yellow skin, right? So, that just be aware that you may see that in just a normal older adult. Okay. So when we're assessing this system as nurses, we're going to be asking our patients about their chief complaint and the history of their present illness. Okay? We want to see what's been going on with them. Are they having trouble with bruising? Are they bruising very easily? Is it difficult for them to get bleeding to stop? Think about it. We're talking about folks who have problems with their red blood cells, their platelets, and their white blood cells. So we want to know, when you have problems with platelets, you have problems with clotting. So we're asking about those things. Are you bruising? Are you bleeding a lot? Do you bleed very easily? Even when there's no trauma. Okay? We're asking about chronic fatigue. That's one of your first symptoms that your patient is anemic, is that they just are fatigued all the time. No energy. No giddy up at all, okay? So when they're having these kinds of problems, there may be issues with underlying disease. So we have to be aware of that. When we're asking them about their past medical history, these are some of the things that we're wanting to know. Okay. Do they have they had cancer, or have they had any prior treatment for cancer? What does that do to your bone marrow? It knocks it out. Right. It decreases the production from the bone marrow. Do they have HIV? Problems with their liver? Problems with their kidneys? Have they ever had any kind of malabsorption disease? What does that mean? Right, they're just not absorbing their nutrients and their vitamins the way they need to. And we're going to talk about an anemia that has a malabsorption issue associated with it. Again, we're wanting to know if they've ever had any delayed bleeding. Is it taking them a long time to recover or heal from surgery? Are their scars just not healing right? Okay. Do they have prosthetic heart valves? Or indwelling venous access device? What would that be like? Like a central line that's under the skin, right? Like a portacath? Why am I concerned with those two things about prosthetic heart valves and indwelling venous access devices? Why, from a hematologic standpoint, am I concerned with those issues? Infection, but also what? That's infection. What else? Clots, right. You got to be concerned with clots. Okay, good. Y'all are critically thinking this morning. I love it. Great. Okay. We want to know if they have ever had any blood transfusions. And of course, we always want to know what kind of medications are they taking. What are they taking? What have they been taking? Especially when we're wanting to know about the last 3 to 4 weeks. Okay, has there been any changes? Okay, we're looking for things like antibiotics, because antibiotics can affect your clotting, and it can also depress the bone marrow. We're asking about blood thinners and NSAIDs, because those cause changes in their clotting ability. So when we're asking about these medications, we do want to know about over-the-counter stuff. What kind of herbs are you taking? Those kind of things. Garlic can mess up with your clotting as well. Can you tell me what the difference between an anticoagulant and a fibrinolytic medication is? What's the difference? One prevents clotting and the other one breaks it up. Which one does which, Rhonda? You got to narrow that one down, honey. Anticoagulants prevent the blood from clotting, or it slows it down. Okay. And then your fibrinolytics actually break down the fibrin in a clot. So your heparin, your Coumadin, those things are not breaking down clots, right? Those things are preventing clotting. when you start talking about MIs and strokes and those type of therapies that you're doing within the first hour or so of symptoms, that's when we're using those fibrinolytics when we're trying to break down the clot. So there's a difference. Make sure you know the difference in those two. Okay. We want to ask our patients about their family history. We're wanting to know, do they have any history of sickle cell disease? We'll talk about that in great detail today. We're also going to talk about hemophilia. These things are genetic. That's why we're asking. Okay. And then we want to know, does a person have any kind of frequent nosebleeds? That may be an undiagnosed hemophilia there in the family. We want to ask, has there been any family member that has died at a young age for reasons other than trauma? This may indicate that they have some type of genetic hematologic problem. Did your patient or anybody in the family have any problem with postpartum hemorrhage? And is there anybody who's had any history of heavy bruising with minimal trauma? Heavy bruising, yes, yes. So family history is important when we're looking at some of these hematologic things, because a lot of them are genetic. So we've asked about their history. Now we want to do their review of systems. Review of systems. Right? We're looking for, have you ever had kind of questions. Okay? So when we're looking at the general appearance, we're kind of just looking at the general appearance. Is your patient pale? Are they awake? Are they alert? Those things you learned in 103, right? Bring them back to the forefront of your head. Okay? What do they look like? Or is this a well-kept individual? Or are they just so chronically fatigued that they can't even brush their hair? Okay? Looking at those type of things. When we're looking at the head, eyes, ears, nose, and throat, we're asking about dizziness, vertigo, confusion. We're asking about pain. Do they have headaches? Have they had any change in their vision? We're looking at their skin, color, skin dryness. Do they have any itching? What about their fingernails? Are they brittle? When we're asking about the cardiac system, do they have any chest pain? Have they had any palpitations? Have they had any instances where their heart just feels like it's running away with them? Respiratory, have you had nosebleeds? Have you coughed up any blood? Are you coughing up anything? And if you are, what color is it? Okay. Have you had any shortness of breath? And you may want to ask them, when does your shortness of breath happen? Okay. Because people should be able to walk from here to here with no shortness of breath. But a person who's anemic, they may not. They may get winded just walking that short distance across this room. So when does the shortness of breath happen? And how long does it take for it to resolve? Or what resolves it? We want to know as far as the GI system. Have you had any changes in your eating habits? How is your appetite? Have you had any nausea and vomiting? And have you noticed any blood either in the vomitus, emetus, or in the stool? Have you had any bleeding in the mouth, the gums? Do your gums bleed after you brush your teeth? You're also wanting to ask them about what is their normal bowel function and have they had any changes in that as well. The genitourinary system, have you had any blood in your urine? Have you noticed any changes to your urine pattern or your urine output? We're also asking women about their menstrual cycles. Are they normal? And you know what normal is across the continuum, but when you're looking at normal, when you're looking at menstrual cycles, you have to say, is it normal for you? Okay? Is it abnormally heavy? How do you judge that? You ask them about pad counts and that kind of business, right? Good. Good. Okay. When we're looking at endocrine, we're asking about, diabetes and thyroid, and have you had any kinds of problems in keeping those within normal limits? Is your blood sugar under control, et cetera, et cetera. Neurologic. A lot of the vitamins and nutrients that you take, they have a direct impact on your nervous system. Okay? So we're asking about, we're asking them about their headaches and do they have any problems with cranial nerve type things. When we're assessing, that's what we're looking at, those cranial nerves to see. Do we have any irritation there or problems there? And then musculoskeletal, asking about joint pain. Remember, we're kind of talking about bone marrow. So your patients who have problems with bone marrow may have pain in those bones because the bone marrow is trying to overproduce. Okay? So they may have sternal pain. They may have pain in their long bones. They may have joint pain. So you're asking them about those kind of things. Do they have cold intolerance? And then you're asking them about frequent infections as well. Right. But your most common first sign of anemia is going to be fatigue. That's your most common. We want to ask our patients about their function in normal everyday life. Okay, what do they do? What kind of work do they do? What kind of hobbies? We're looking when we're talking about the hematological area, we're looking at toxins, exposure to chemicals, those kind of things. Okay. We always want to ask about self-concept. We ask about activity and exercise. Again, trying to drill down some of that information about fatigue and, what is their ability to walk across the room. Sleep and rest patterns are important. We're asking about interpersonal relationships because we need to know about their support systems. Coping and stress management abilities. What is their perception of their health? And of course, we want to do a nutritional assessment as well. Okay. Patients who have diets that are high in fat and carbs, low in protein, iron, or low in vitamins, those people have a big risk for anemia. High in fats, high in carbs, or low in iron, protein, and vitamins. If it's high in the bad stuff and low in the good stuff, you can have a risk for trouble there. We do want to ask about alcohol consumption because of the liver damage potential. And then just keep in mind, some patients have a diet that predisposes them to clotting factors. Like what? People who eat a lot of the leafy green vegetables, that increases their vitamin K. Okay? So they can have issues with clotting. So somebody who eats a salad twice a day, every single day, we need to be aware of that. Or the potential for that. Okay. Questions about the history, the review of systems, and the functional assessment. You really want to do your functional assessment on your patients who are newly diagnosed with hematological problems. Right? Because we're trying to look for the source of the problem. Maybe it is diet related. Maybe that's, they need to cut down the salads. Maybe it's something as simple as that. Who knows? But do you find yourself asking these questions of all your patients? Pretty much you do. Because you're trying to get what? A baseline. So it doesn't matter if you're looking at a cardiac issue, a respiratory issue. You still want to know about your patient's history, their current level of functioning, and then what kind of family history they have. Okay. That's why admission assessments are so lengthy, is because you're trying to get that baseline. So when you're admitting patients to your units, you're going to be doing like those comprehensive things that we make you guys do. So y'all think you're just not going to have to do that once you get out of here, but I'm sorry, you will. It'll just be a little shorter, okay? All right. No questions about that. You're good, right? All right. So we've found out everything we ever want to know about their history and their family history and how they've been doing. Now let's see how they're doing today. Let's do their physical exam. Okay. Keep in mind that any decrease in oxygen delivery affects tissue perfusion and eventually affects the whole system, the whole body system. So we got to look at the whole body. All right. We're going to start out with their vital signs, height, and weight. If you have somebody who's having problems with their blood, what kind of changes to their vital signs do you think you will see? Low blood pressure, okay, so hypotension. Increased heart rate, so tachycardia. They may have a low temperature, sure might. What about their respiratory status? Right, your patients may be tachypnic. Okay, so we kind of expect to see that if we have a patient who's anemic, right? When you're talking about your blood pressure, these folks are very prone to orthostatic drops in their blood pressure. So we want to make sure that we get those levels on admission. And you may even be asked to get those like once a shift or every 4 hours or something like that. Okay. So orthostatics are really important in these folks. With your general survey, you want to look at their responsiveness, their mood, their expression, their posture, their skin color. They usually appear pale. So your patient may present to you with shortness of breath, and you may think it's a respiratory issue, but it comes down to once all this data has been gathered, it may just be an anemia issue. So am I going to treat the shortness of breath now, or am I going to wait till I decide if it's anemia or a respiratory issue? If I'm short of breath, fix me. Okay, and then we'll draw my blood. Okay, good. When you're looking at the skin, you're assessing for abnormal bruising. You're looking for any kind of changes there. Old bruising. You're looking for swollen, painful areas. Looking for that dry skin. Assessing their nail beds. Their conjunctiva. We're also looking, we're expecting to see pallor, but we may see jaundice as well. Because the liver you may have too many red blood cells and the liver's breaking them all, trying to break them all down, and then you get that jaundice color to the skin. If they're red and flushed, that may be too many as well. Correct. What you mean automatically? Polycythemia vera, right. We'll talk about that. Don't forget, we'll talk about it. You're red. Yeah, you're red. Yeah, you're red right now. If your hemoglobin and hematocrit's that high, yeah, you're red right now. But what happens is as the body's trying to, if you're destroying too many red blood cells, then that's when you start to get the jaundice. But you may not see that until you start to take care of the having too many. And we'll talk about how we take care of that. Okay. All right. So we're looking for. Excuse me. You need to be able to describe the bruising that you see. Okay. Do you know what the word petechiae means? What does that mean? Little pinpoint hemorrhages. Okay. Use the correct term. Don't say little purple dots. Okay. Think about the way your charting is going to look on a big old screen in a courtroom. Little purple dots does not look quite as professional as the word petechiae. Okay? So think about that. You may also use the word purpura. Have you heard that word? What does that mean? That's big old spots. That's big purple dots, okay? Okay. When we're looking at the head and the neck, we're looking for signs of bleeding. Eyes, ears, mouth, gums. We're looking for cracking in the corners of the mouth. We're looking at changes to the tongue. And you see some of these things with different kinds of anemias, and we'll talk about that. When we get to the chest, we want to listen to the lungs. Doing your correct procedure there for listening to all the lung feels. Okay. We're looking for shortness of breath. Okay. We're looking for rate, respiratory effort, all those kind of things. Usually your patient that is anemic does not have crackles and rails and all that business. But oh, Miss Powell, what if they're anemic and they have congestive heart failure? They might have them. Right. Because unfortunately, guys, they don't have just one problem. Okay. All right. We're listening to the heart, assessing the heart rate, blood pressure. Remember your folks. What do you think about their pulses? What kind of changes in their pulse do you see? It may be faster. They may have tachycardia, but when you're palpating their pulse, what do you think? Weak. They may be thready. Right. Just want to make sure that you're checking it on both sides. Remember, it may not be an anemia issue. It may be a circulatory issue. And again, we're checking their blood pressure. The blood pressure is usually a little bit lower systolically in a patient who has anemia than it is in somebody who has normal blood values. With the abdomen, we are doing our normal inspection, listening to bowel sounds, gentle palpation for distension, abdominal tenderness. We're probably going to check a stool specimen for occult blood. And remember, there are techniques out there to palpate the spleen and the liver, but we need to be very careful and very gentle, especially if we're palpating the spleen. We usually just kind of leave that to the advanced practice folks. I've never had to palpate a spleen in my entire life, ever. So if you feel so driven to do that, make sure that you're very gentle with it, because the spleen can rupture, especially if there's something wrong with it. And then, boy, Heidi, do you have problems when you have a ruptured spleen? What do you think you got problems with when you have a ruptured spleen? Not yet. That's once we do surgery. What? Bleeding. It's very, very vascular, and it's full of platelets. So your patient who has a ruptured spleen bleeds internally, quickly, and lots. So you have to take care of that. So be careful if you're smashing around on the spleen, okay? You may need to check a urine specimen for blood, for protein. When you're assessing the musculoskeletal system, you're looking for joint tenderness, pain, Okay, maybe some decreased range of motion because of that, because of the pain, the joint swelling. And then you're also maybe palpating over the sternum, over the long bones to see if there's any bone pain. How do we check the neurologic system? Sensation. What else? Reflexes. What else? Bilaterally. Let's check it bilaterally. Right. What else? Talk to them and have them stick their tongue out and cross their eyes and follow my pen. You remember all that stuff? Where you did a head to toe and you said, okay, that checks 3, 4, and 5. You remember those cranial nerves? Go back and look at that. Okay? Because like I said, a lot of your nutrients, vitamins, etc., affect your cranial nerves, or you have to have certain levels for your nerves to work correctly. So keep that, okay, that check 3, 4, and 5 and all that business that you did, keep that in your head now, because you're going to be doing that. Okay? Do we need a break? All right, let's take about 10 minutes. Now let's talk about some of the diagnostic tests and procedures that you're going to see with patients who have hematologic problems. Of course, we're going to do blood tests. Of course. It's a blood issue, right? We're looking for cell function and cell numbers. And our primary one is going to be a CBC or a complete blood count. Now, those of you who have looked at CBC results, those results tell you what? About 20 different values, right? If you are diagnosing, you're going to need a lot of those, you do use a lot of those numbers. But in just your everyday life, okay, as a nurse, you're going to be primarily concerned with these right here, okay, plus your white cell count. Plus your white cell count. But again, we're not talking white cells in this lecture. Red blood cell count is just that. How many red blood cells we have in a milliliter of blood. We're looking at hemoglobin. You may see that either HB or HGB. That is your oxygen carrying capacity of your blood. Hematocrit gives you a percentage of red blood cells in a blood sample. Platelets gives you an idea about your ability for clotting. In your Iggy book, you have a chart that's 41-3 that gives you basic hematological blood values. You need to look at that so that if you see a blood value, you can make a determination on whether that's high or low. These, for certainly, these four right here. And remember, you've already done this. You looked at these issues when we were talking about post-operative issues, bleeding. You want to know what the hemoglobin is, right? So you've already looked at this stuff once. Go back and refresh your memory on it. Usually your hematocrit is about 3 times what your hemoglobin is. So maybe you only have a hemoglobin level. Okay? Multiply it times 3, and that's basically what your hematocrit is going to be running. Female hemoglobin is usually a little lower than male levels, especially if your female still has menstrual cycles. but they always run a little bit low, a little bit lower than the males. No. Women always run a little bit lower than male. And you're not comparing a females to a male. I'm just telling you they run a little bit lower. You're comparing that female's levels to what the norms are for that lab. Okay? So hemoglobin, hematocrit will run a little lower in your females than it does in males. You're also looking at blood values that have to do with clotting. And what are those? PTs, PTTs, bleeding time, and INRs. Right. So PT, PTT, INRs, and bleeding times. Your patient may have imaging studies done to see if there's any kind of issues with blood cell production, looking at bone marrow. There are some nuclear med exams out there where your patient is given isotopes, and we look to see if it's absorbed into the bone. Looking for hot spots is what they call it. Okay, but one of your main definitive studies to see about issues in the bone is a bone marrow aspiration or biopsy. This is where you actually put a needle into the bone marrow and pull out fluid, which hence aspiration, or a biopsy where you actually pull out a core of tissue. This is a picture of it here. This can tell you about bone marrow activity, about blood cell production, and it can also tell you about the spread of cancer. Sure, it tells you about bone marrow activity, blood cell production, and it also tells you about the spread of cancer. We'll talk about it. This is a procedure that usually takes 15 minutes to 30 minutes. It can be done at the bedside in the patient's room. So you need a consent. This is invasive, so you need a consent. Your patient needs to understand risks, benefits, what they can expect, what the procedure is like. Okay? Whose responsibility is that? That's the physician's, and you're clarifying and getting the consent signed. Okay? It is a sterile procedure. So there's usually a bone marrow tray, just like there was a trach tray and a central tray and all those trays out there. There's a bone marrow tray that has all your stuff that you need and all the syringes and the needles, etc., etc. Now, Marcus asked about anesthesia. This is usually done as a local. They will deaden the site, but also we use moderate sedation in these folks as well. I'm going to need some Versed, okay? And just go ahead and have the syringe ready. I may need 2 doses, okay? If you get your patient comfortable, they usually do okay. It just seems like it's so painful. They're sticking a needle like this into your bone. It's not the nicest thing to watch. It really isn't, because you don't, you have a large cord needle here, As you see, it's a large gauge. Yes, ma'am. No. No, that's like a blood infusion. So, we do a local anesthetic. We do a moderate sedation. The site is usually either going to be in the iliac crest, so your patient needs to be positioned either prone or laying on the side, on their side, or it may be in the sternum. They may take do it from the sternum. I'll get there, Marcus. Hold on. I'll get there, Marcus. You about 4 steps ahead of me. Okay. So, when we're talking to our patients about this procedure, they need to understand that it's relatively quick, okay, but they do have some sensation, okay. They will feel pressure in their hip, okay, or the sternum as the physician is trying to get the needle into the bone, because you have to go through the outer, the hard plate of the bone and into the marrow, okay? And it is done with a force and a screwing type pressure to get that into that bone. Okay? So your patient will feel that. If you give them enough Versed, they don't really care that much about it, but okay, but they do feel it. They may also feel a crunching type pressure. Okay? They don't use it. It's so quick. And you think about the risks and benefits of anesthesia for a 2-minute procedure. Yeah. Versed works wonders. I'm telling you, Versed, you get your patient comfortable. Get your patient comfortable. Okay. And again, it looks a lot worse. You know, most of your patients do fine with this, but give them some medicine. Give it to them. Give it to them. I'm going to need some. I'm telling y'all, I'm going to need some. So, once the procedure is over, okay, post-op care, you've accessed the bone marrow, so you have a risk of bleeding. So these people have pressure dressings applied to the site, and we usually keep the pressure dressing on for about 24 hours. Okay. We're monitoring that site every 2 hours for the first 24 hours. We may put ice packs on it, and we give them some mild analgesia. This is not something that they have horrific pain after. Okay. Yeah. It usually, if they're brought in to have that done, it says an outpatient, and they come. So that's why we educate our patients. Look at the site every 2 hours. Don't take this dressing off. Okay. Sometimes they'll come back the next day to the physician's office and have the dressing removed. It just depends on what the physician has ordered. Okay. But we keep the pressure on. We monitor. We make sure that they know not to do any kind of contact sports, no kind of risk of trauma to that area for a good 48 hours. So they need to go home and take it easy. Okay. And your patients that are having this done as an outpatient, we really are going to monitor them for a good the first couple of hours, because they're going to have that really good apply pressure kind of thing to them for 2 hours. That way, if they're okay and they go home, they still have the dressing on there, but the longer they go without having active bleeding, the less chance it is that they're going to have active bleeding. So we make sure we've got that pressure dressing on for a good 2 hours, but we usually just let them go home with it on too. Okay. I'm not going to ask you about times. I just want you to know the patient's got a pressure dressing on after this. Okay? All right. So that's our care for the procedure. Refresh my memory about care for a patient who's having moderate sedation. Huh? Gag reflex. Why am I concerned with the gag reflex with this patient? I'm not concerned with the gag reflex on this patient. I have not sprayed anything in the throat. I have not deadened the throat. How do you monitor a patient that has conscious sedation, moderate sedation? What do you need? What do you need? What kind of equipment do you need? You got a patient, Gabrielle, you got a patient that's going to be put on moderate sedation. You're fixing to pop them with some Versed. What do you need to hook your, what do you hook your patient up to? You put your patient on oxygen. What else? What else? You're going to put them on the cardiac monitor. What else? Your pulse ox. Thank you. I need to know, are they breathing? What else? We've got pulse ox. What else? Yeah, let's put me on continual vital sign monitoring. So you've got to monitor their vitals, their pulse ox. You've got to monitor their level of consciousness. You're fixing to give them sedation. You are not an anesthesia provider. You have to monitor this patient. You have to have an IV line going in case something happens and you've got to give them some medication. What is the antidote for Versed? What is the antidote for Versed? Romazicon. Who said that? 2 points, Kendra. What is Narcan the antidote for? Narcotics. Okay. So I'm not concerned with you're going to sedate your patient. You've got them flipped over, face down on the bed. You got to be able to see your patient and monitor your patient. You're not standing there going, "Oh my God, I know that hurts." You're looking at your patient. Okay? You're looking at their color. You're looking at their level of consciousness. Have you sedated them so much with Versed that they're not breathing? It's important to know that. Bring that knowledge back, guys. We've already talked about this stuff, okay? Bring it back. You're going to see it again. So that's the stuff you need, plus the stuff that you need for the procedure itself. Okay? Good. If you know, the physician's going to come in and he'll say, "Okay, let's do a bone marrow today. We're going to give him some Versed." Okay, you know that you're going to need a bone marrow tray, and if he says Versed or a little sedation, you know you have to pull up to either your policy or to the forefront of your mind. You're going to be doing conscious sedation or moderate sedation on this patient. Following your policy, those are pretty much the things you're going to have available. So you know you're going to have the medicine, and usually your trays or whatever you have that you bring into the room will probably have some Romazicon. Because again, you're giving anesthesia outside the usual realm of where anesthesia is provided. So you still have to meet those same standards. You have to be able to quickly reverse the effects of those medications that you give your patient. Okay, so be ready. Be ready. Okay. So we're not concerned with their fluids and all that business. Now, Ryan, you're so right. Now, if I have a patient that I'm recovering from moderate sedation, and we've had them so snockered that they have really been unconscious, we are going to be assessing their swallowing ability and their things like that, ice chips and started. But as far as like the way you guys are thinking, gag reflex, it doesn't really fall into this category because we have not deadened the throat. Okay? Any questions about bone marrow biopsy? You'll be prepping them. You'll be getting the consent signed. Usually there is a lab person in the room when you're doing those procedures so that the physician can immediately hand off the specimen to the lab person for immediate processing. Okay? Processing, staining, whatever they do. That's their responsibility. You're not going to be doing that. Your responsibility is who? The patient. Okay? All right. Good. So when we're talking about patients who have hematological problems, these are our two big risks here. They have a risk for injury related to low red blood cell counts. Bless you. And they also have a risk for injury related to bleeding. Again, we're only talking RBCs and platelets. What's your risk when you have too low white blood cells? Infection, right. So we're going to be talking about issues with transfusions, oxygen, prevention of bleeding, those things that maintain their oxygenation and maintain their hemostasis. Think about those concepts. That's what our goal is here. Okay. Now, I want to briefly go back over blood transfusions. We talked about the why, the how to do it kind of business, but let's kind of go back over. Remember, the first thing you got to have is typing done. Because you guys are going to be giving blood transfusions for some of these problems. So we got to have a blood type done. O negative is our universal donor, and AB positive is our universal recipient. When we're talking about transfusing packed cells, remember, any kind of blood transfusion, you must have a consent. How many of you are working out there in hospitals? Do you have a separate consent for blood administration? Yes, we do at mine. I just wondered if you did, because usually a consent will cover everything, but we have a separate one for blood. So, okay. We do get the consent signed. We get blood sample drawn and sent for typing and cross-matching. We make sure that we know what our policy is regarding blood administration. Bless you, blood administration at our hospital. Okay. There are different types of transfusion that we've talked about. You may have an autologous where the patient actually donates blood ahead of time for us to give back to them. All right, that's autologous. A directed donation, what's that? Right, you have blood that is donated for a specific person. Okay? You already know who the recipient is going to be. And then a volunteer donation is just like your blood drives. You volunteer, go in and donate it, and it's, anybody could potentially receive your blood. Which one of those is the safest? The autologous, of course, to cut down the risk of infection, the risk of reactions. Certainly, if you give and you get it right back, that's the best way. But we don't always have that opportunity, do we? Now, when we're transfusing packed cells, that's a volume of about 200 to 250 milliliters in one of those bags. What is my infusion time for a unit of blood? No more than 4. It's got to be hung. No more than 4. How fast do you have to get it started once you get it out of the lab? 30 minutes. You got to have it started within 30 minutes. Good. And we're really looking at, remember we talked about, we just don't give blood if we think, hey, that may help. There's got to be documented reason for us to administer blood to a patient. All right. Usually if the hemoglobin has started to drop, once it falls below 6, that patient is getting blood. And then it's kind of doctor's preference between 6 to 10. Those are just numbers there, guys, okay? Your physician may transfuse your patient when it's 10 or when it's 9, based on what's going on with the patient, how quickly they're losing blood. Mm-hmm. 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 Breaking down. Mm-hmm. It starts breaking down. Yeah. They usually store it for a few weeks. They can store it for a few weeks because remember you can't donate every day. Every 5 to 7 days you can donate. So it depends on how many units you want to give, but they can store it for a while. I'm not sure. I can't quote you the exact blood bank numbers, but it can be stored for a while. So remember your hemoglobin is going to be around 12 to 16 for your females. So when it starts to get below 10 or so, they're going to start thinking about transfusion. And the patient who is below 6 is pretty much getting blood. Pretty much going to get blood. You may be asked to transfuse platelets. Now, our normal platelet level is between 150 and 400,000. 150,000 to 400,000. All right. So once if your patient is actively bleeding and their platelet level has fallen to about 50,000, that person's getting platelets. And they're definitely going to get it when it falls below 20,000. So what's your risk here? If you have platelet levels that are low, you can't clot, so you bleed. All right. So with those platelets, you got to have a consent. Still get blood typing done. Got to know your policies, and usually your platelets are ordered either a platelet phoresis pack, which is like, it almost looks like a unit of blood. It's like a 200 cc bag of about 10 units of platelets, or you may have individual units of platelets ordered. Give 10 units, give 5 units. Okay. In that case, that's something that they have to be administered quickly, because what do they do if they're just idle? They clot, right? So the times that I've given individual units of platelets, I've had somebody in the room with me shaking the bags, because you're pulling from the bag, you're pushing it in your patient, you're pulling from the bag, you're pushing it to your patient. This is not a slow transfusion. Okay. Now, if you're giving the platelet phoresis pack, which is the big bag, that can be transfused over a couple of hours. Okay, I understand there's something in there that prevents those from clotting. But the individual bags, the individual packets, you're pulling them and pushing them in quickly. To 400,000. I think that's what Iggy's got as norms. If they're below 20,000, they're going to be transfused. But if they're actively bleeding and it falls to 50,000, they're going to get platelets. Because it's just going to continue to fall, right? There is special platelet tubing that you administer platelets with. It prevents it from sticking to the inside of the tube. And when you give platelets, be aware that your patient may have fever and chills, but it is not a true reaction to those platelets. Not like when you think of a blood reaction. Fever and chills. So platelets we give quickly. Fresh frozen plasma is another component you may give. Remember plasma is the liquid part, right? A lot of proteins, globulins, all that business in there, albumin. So when blood is drawn, it is separated from whole blood and quickly frozen. So it contains all of those proteins and it contains all the clotting factors. When you're giving fresh frozen plasma, you are trying to replace blood volume. Part of your plasma, which you may be asked to give cryoprecipitate. What that is only the fibrinogen and then the clotting factor 8. So those can be actually pulled out from plasma and given separately. Okay, but your physician orders that. And these are given rapidly as well, fresh frozen plasma. I'm not going to hold you to a time frame because it changes a little bit from place to place. But this is not something we hang up there and let infuse over 4 hours. So we're replacing blood volume when we're giving frozen plasma. You may just give plano albumin, which is just the albumin without the clotting factors. Lots of different blood components that you can be asked to give out there. But again, look at your policy. See what your time values are, your time levels. The majority of what you're going to give is going to be your fresh frozen, your pack sales. Sorry, pack sales. Okay. When we're talking about blood reactions, there are 4 main types: hemolytic, anaphylactic, febrile, and then circulatory overload. When I have a hemolytic reaction, this is from an ABO incompatibility. Your antigen and your antibodies are reacting. It's from an ABO incompatibility. Antigens and antibodies are reacting against each other. Anaphylactic reaction is just that. They're just having a reaction to the blood itself. It's not the ABO incompatibility. Okay? It's an allergic reaction. Your febrile is where your patient, the antibodies are reacting to leukocytes that are in the blood that you're giving your patient. Now your typing and cross-matching may pick up on this risk for a febrile transfusion. That's why you may give some blood with a leukocyte filter attached to it. To kind of take away those leukocytes to cut down on your patient's risk for febrile reaction. And then, of course, you can always put your patient into circulatory overload when you give them blood. Blood is a volume expander, right? Plus the fact that if you're giving fresh frozen plasma, that's expanding volume as well. Yes, ma'am? Febrile, it's where your antibodies are reacting to the leukocytes that is in the blood. So sometimes when you type and cross-match the blood, it'll pick up on that your patient's blood is reacting with the donor. So you may be asked to attach a leukocyte filter to your blood tubing so that your the donated blood flows through that before it gets to your patient and it pulls out the leukocytes. Okay. Signs and symptoms of a blood product transfusion: they have back pain, fever, chills, they may have chest pain, blood pressure drops, they have urticaria, which is the itching, rash, wheezing, dyspnea, coughing, those kinds of things. Okay. So when you have that, what do? You stop it. You stop the transfusion, disconnect that blood line, and connect it up to normal saline to keep it open. Immediately assess your patient. And while you're doing that, somebody needs to be notifying the physician, the nursing supervisor, and the blood bank. But you take care of your patient first. Okay. So we've stopped it. We've got them hooked up to some saline. We need to be prepared to put your patient on oxygen. We may give them epinephrine, with especially if it's a true allergic type reaction. We may give them steroids, Lasix, and then antipyretics. This stuff's going to be ordered by the physician, but you're also going to have a protocol, I'm pretty sure, in your facility that if a patient starts to react to blood, here's your steps. Now, contacting the physician will be one of those steps, but you may have some protocol out there that allows you to intervene with your, epi and stuff like that. It may. Make sure you know what your place says. Kendra, did you have a question? Continue to monitor your patient, and if you ever question, her question was if you're having those types of reactions to the plasma, fever and chills you may see. Now, if they're starting to have shortness of breath and rash and back pain and all that, you got to stop it. But if you ever question about what's going on with the patient, you just stop it. Okay, that's safer. That's the safest thing to do for your patient. And I have stopped a blood transfusion before and called the physician, and he's like, give him some Benadryl, give him a little Lasix, and then start it back and slow it down. Okay, but that's his call. Okay, and the patient has been fine, but I wasn't comfortable. In continuing that, because you don't know. They don't usually have fever and chills with packed cells, no. But you can see it with plasma, the fresh frozen plasma. Distinguishing between what? Well, let's just say, without even thinking about the test, you're standing at a patient's bedside, okay? And you're administering, you have started fresh frozen plasma on your patient. And you know that patient could have fever and chills, okay? You're standing there at that moment in time. Your vital signs, if everything's been good, you started it, your patient starts to have fever and chills. What would you do? You don't have 4 things to choose from on a test. What would you do? Yes, ma'am, you sure would. You would watch them, assess them, see what I need to do. If my patient is getting worse, or if I'm just really not sure, I'm going to cut that off. I'm going to take their vital signs. I'm going to call my doctor and see what he wants me to do. When you're standing at that patient's bedside, you have to make that choice. You have to make that choice. And something in your STEM, if you see that on a question, should be able to lead you toward the right answer. Okay? I mean, you cannot, that's okay. I want you to think about, though, not how I'm going to write the test question. What am I going to do? What are you going to do standing at that patient's bedside? You are not going to cry. You are the nurse, and you have to put your nurse face on and take care of business. Okay, moving on. Okay. Remember, we talked about when you have a reaction, we're not just going to take all that blood down and throw it away, right? We're going to save those little pigtails that are at the bottom, because further testing will need to be done on that blood. And then we need to be prepared to have blood samples collected and urine samples. Why urine samples? Why in the world do I care about a urine sample if I have a patient who's having No. What happens when you have ABO compatibility and you or a true reaction where your antibodies and antigens are fighting those red blood cells? What does it do to them? It breaks them down and they spill out into the urine. Okay? Well, that's what you're looking for. You don't have blood byproducts in the urine if it's just a minor if it's fluid overload or if it's febrile, okay? You see that with AB incompatibility. So be prepared to get those, okay? All right, one more and then we'll take a break. Yes, ma'am. You see red blood cells in the urine. Now, you may be asked to give what we call colony-stimulating factors. This is your epigen, which is erythropoietin. This is, remember, that hormone that is secreted by the kidneys that kicks in RBC production. Okay? So it stimulates the bone marrow to produce more blood cells. It is an IV push. Now, the effects on your patient's hematocrit, because remember, hematocrit is your percentage of red blood cells. So your hematocrit change does not occur for several days. So if you need if you've got a patient who has a hemoglobin or hematocrit, of 10 or whatever, you can't wait for that person to build their own red blood cells back. You have to administer cells at that time. So what kind of patients are you going to see Epigen given to? Cancer. You're going to give it in anemias, but what else is going on with your patient? Why cancer? Why do you say cancer? Because cancer and your chemos and all that disrupts your bone marrow. Correct. What else? Kidney failure. My kidneys aren't working, so they're not secreting erythropoietin. So maybe I need to give that to my patient. All right. Good. Break. Let's take about 10 minutes. We'll come back and we'll talk about specific examples.